Thank you very much for this kind invitation. The problem of today is related to the if anemia is a battle of the past, but I think that for sure is a hot topic of the day. I think that is absolutely important. How to manage anemia? We will have many discussion about that. For sure, you can use ESA, iron, both, blood transfusion, you heard it before. And I think that there are many possibilities, so it's up to us to select the best way for treating anemia. But let's start with the very important trial published almost 20 years ago. 10 years, you can see here, more than 12 years ago. And this is the trial on dialysis patients, and was the first one with the idea of to try to normalize the hemoglobin level, in this case was hematocrit level, versus the partial correction of anemia. And of course the population, this is the population in the United States, so there are some important differences related to Europe. For example, the use of graft as a vascular abscess for dialysis was impressive. In Europe, the percentage is 5%. Also, there are some problems because the population was a lot of comorbidities, particularly the heart failure was a very important problem. But, of course, what is important to underline is the number of transfusions. Even in case of patient with 42, you can see the number of transfusions was 21%. And, of course, in the lower hemoglobin target, the percentage was 31. So I think there are, in any case, a very large percentage of patients that receive transfusion, and this is a trial, so you have to take into consideration is a selected population, selected doctor, selected patient, what do you want? And in any case, you can see here, even if the trial was negative, so there are more comorbidities, more death in patients treated with higher hemoglobin level, for reaching higher hemoglobin level, you can see in any case the patients that were able to reach the target have the lowest mortality in comparison with the other population. But what is strange is, for example, for the cell level of the hematocrit, you can see here, there was an impressive difference between the patient randomized to normal hematocrit level versus the patient randomized to the low hematocrit level. So I think that every time we are considering the trial, we have to have a look at the way we are correcting anemia for the outcome of the patient. Because at the same level of the hematocrit level, you can see the mortality was completely different. But of course, considering the situation related to dialysis patient, the idea of the nephrology was we have to start earlier in order to reach the best results. And this was the first one trial was designed for normalizing the hemoglobin level in the chronic kidney disease patient. And of course, you can see here the inclusion criteria were hemoglobin level between 11 and 10.5, and glomerular filtration rate between 15 and 35. You can see two targets, one 13, 15, and the other one just partial correction anemia, 10.5, 11.5. So-called early intervention versus standard intervention. And I'm very pleased to have in this room Dr. McDougall, Dr. Kayuber is not here, but was part of the group. You can see here the transfusion were, in any case, 8.7% in the higher, also called the early intervention group, and 11%, let me say, in the lower group. So even in patients with relative well-preserved GFR, and of course selected population, you can see the need for transfusion is absolutely important. But there was another, what is important to underline is the level of the hemoglobin in this patient population. Because we are discussing of not treating the patient that is much better than reaching the higher hemoglobin target, You can see this is the target of the experimental group, so this is approximately 13, and this is the target of the control group. The yellow line is the range target foreseen by the protocol, and this is the value reached during the trial follow-up, and 11 is the minimum level suggested for the guideline. So this is important for underlining that all these trials are comparing a value suggested for the guideline with the normalization of the hemoglobin level. In the same issue of the New England Journal of Medicine was published the QUIET study, and in this situation, comparing a hemoglobin level of 13.5 versus 11.3, where was a 34% increase in the mortality in the higher hemoglobin group. And this was, for sure, for us, very disturbing because everybody was thinking about the possibility of improving the outcomes of our patient, normalizing the hemoglobin level. Unfortunately, there are no data on the transfusion in this trial available, but in any case, you can see again, we are comparing a very high hemoglobin level versus the hemoglobin level foreseen for the guideline. So that is important for considering the need for transfusion of the control group. The control group is exactly the value suggested for the guideline. But you know, this is exactly the value, the minimum level suggested for the guideline. You can see here during the trial follow-up, the hemoglobin level were higher. But again, we have the last trial that is absolutely important for trying to clarify the issue of how to treat our patient with ESAs. You can see here was related, this trial was related to patients with type 2 diabetes and chronic kidney disease, of course. The randomization was 2,000 to hemoglobin target of 13 using darbepoetin for reaching the target. And the control group, the so-called control group, was 2,000 patients. They have to be treated with placebo, with the possibility of a rescue treatment in case of hemoglobin level less than 9. So you can see very important difference between the two groups. And again, the study population enrolled in the trial should have an hemoglobin level equal to or less than 11, and a glomerular filtration rate between 20 and 60, and of course, type 2 diabetes. You can see, so the numbers are very important, and this for sure is the best trial that till now has been published in the literature about the treatment with ESA in a chronic kidney disease, even ESA just type 2 diabetes. You can see the follow-up was 29 months, and the total patient here observation was very important. But look at the data. You can see here that the situation is very strange because while the experimental group reached more or less the value that was foreseen by the protocol, 12.5 grams per deciliter of the hemoglobin, you can see the behavior of the control group was very strange, the so-called placebo group, because we started with 10.4, you can see here, and the patient finished with 11.2, with a median value of 10.6. This, of course, is absolutely strange because normally we are expecting that the control group is decreasing the hemoglobin level during the trial follow-up. So the behavior of the placebo group was exactly the opposite. And you remember the patient should have reached an hemoglobin level of 9 before receiving any kind of treatment. And let me say that 36% of the patients received darbepoetin in the control group, but the median value was 0. That means that this patient received, by chance, one dose of darbepoetin because of some intercurrent comorbidities without any need for the treatment. So I think that if you remember, the value that suggested for the guidelines was to have at least more than 11. So in any case, also this trial is comparing the higher hemoglobin level with the value suggested for the guidelines. But I think that and so you can try any conclusion about the fact that you should treat the patient only in case they will reach an hemoglobin level below 9, because the data are absolutely, according to the result, is absolutely impossible to have conclusion about the fact that the patient could safely reach an hemoglobin level less than 9 before being treated. And what is important to have a look at is the number of the transfusion in this patient population. And even in the higher hemoglobin level, you can see the percentage of the transfusion was approximately 15%, and in the so-called placebo group was 24.5%. So I think that these data are impressive. So you can imagine if the median value of the placebo group was 10.6 grams per deciliter, you can imagine in case actually the patient were able to reach the value of less than 9 suggested by the protocol. So I think that this is one of the reasons why in the debate with Dr. Singh, of course, we clearly underline that also for the CKD population, the target should be maintained, the hemoglobin target should be maintained between 11 and 12. Of course, with some caution in diabetes with CK2 and dialysis and history of stroke of malignancies, because the trial was underlined in secondary analysis a very important risk of strokes in patients with previous history of strokes and, of course, in the patient with malignancy. So some caution in this patient population should be taken into consideration. But for sure, transfusion avoidance is important, and the maximum dose of iron should be determined with ESA dose and caution for hyperresponsive patients in order to avoid to use too much ESA. So we have not just to look at the level of the hemoglobin, but also the amount of ESAs for reaching the hemoglobin target. And very recently, we published the position statement of European renal best practice, because we moved from European best practice guideline just to European best practice after the KDIGO, because KDIGO is an international body for organizing the general guideline. So we decided as European to have an European point of view, just giving some statement about the major problems. And of course, we did it. You can see here McDougall is a part of the group, discussing the position statement of European renal best practice about the trial. And our, of course, one of the major issues was related to the fact if the blood transfusion is a feasible solution. And of course, one of the comment was to never forget where we are coming from, because these are the lucky 13 first chronic hemodialysis patients at the Royal Free Hospital in January 1965 that were the survivors. And I think if we are old enough to remember that in this case, we are very happy in case the patient were able to reach 7 of the hemoglobin level, because ESA was not available. And we have to give the patient transfusion and transfusions, and they are just able to survive without any possibility to take normal everyday clinical activities. But I think that we have already heard many problems related to transfusion risk, and I would like to go back to 1989, when the FDA approved the use of EPO-alpha for the treatment of anemia associated with chronic kidney disease to elevate or to maintain the red blood cell level and to decrease the need for transfusion. I think what the story was already written many years ago, so you should try to avoid the transfusions as much as possible. And for sure, you just to remember the percentage of the transfusion in the trial, so you can imagine, I would like to underline, the trial is a selected population, so even in the selected population, I think that this percentage are very impressive. And also, if you are considering the higher hemoglobin level, there is a risk, but there is clear difference between the two groups. So decreasing further the hemoglobin target, for sure, are increasing the risk of transfusion for our patient population. And again, you can see in any case that it's important to underline that for the general population, but also for the CKD patient, there is a clear trend in the decrease in this transfusion. But I think that now, 2004, was just before the publication of the CREATE, the QUIRE, and the TREAT trial. So I'm not so sure that this trend will be still present here, so I'm very curious to see the result, because probably there is an increase in the need of transfusion after the publication of this trial. But what is important to underline again is this retrospective analysis for considering the patient with CKD not on dialysis, chronic kidney disease, not on dialysis, and with anemia. You can see considering altogether the number of the transfusion are important. But what I would like to underline here is that this is the fact in case you have no therapy. You can see the number of the transfusion is important, even when the hemoglobin level are not too low. You can see here why, if you use iron, or if you use ESA, or if you are using a combination of ESA iron, you can see you can dramatically reduce the need of transfusion. So I think that it's important to be aware of this impressive difference between no treatment and the treatment. So going back to the position statement, of course, in the position statement of European renal best practice, we underline that the risk-benefit of increased transfusion should also be considered carefully, especially in patients eligible for transplantation. I think that this is another important point, because the population that is in waiting list for transplantation, the risk of transfusion is another important point. And because you remember, just for concluding my presentation, broadly speaking, anemia management consists of ESA therapy, iron supplementation, and red cell transfusion. And avoidance of the latter is particularly important in patients eligible for renal transplantation, where exacerbation of HLA sensitization should be avoided. And also we have to take into consideration the other potential risk of the transfusion that, as I told you before, we heard already. So I think that in general we can say that to make a joke, you can say that for treating anemia we need a magic formula, and I think what is important is to mix everything together using wisdom. Thank you very much for your attention.
So, dear colleagues, ladies and gentlemen, thank you very much for inviting me to participate to this meeting. So, despite the advances in the surgical techniques, we have to admit that blood is still frequently used in the surgical setting, as shown here by epidemiologic studies published in the UK, that about 40% of blood is still used in the surgery patients. Another important point to take into account is that despite the publication of numerous guidelines, still a high number of patients receive the famous 2 units of blood, which may indicate that there is a empty room for improvement in the context of the surgical blood usage. Surgeries associated with the most common use of blood are, of course, orthopedic and cardiothoracic surgery, and I will focus my presentation on these 2 particular surgical specialties. I think the major problem we have in surgery is the variability in transfusion practice. This point has already been emphasized by Philip Bale and co-workers from a Brussels group evaluating the transfusion practice in cardiac surgery in orthopedic surgery and in hemicolectomy. And before the year 2000, you may observe the huge variability in the transfusion rates among these different studies. Does the situation change in 2010? Not at all. This is a study that has been published recently by Bennett Guerrero and co-workers. It is an observational cohort study of more than 100,000 patients undergoing coronary artery bypass graft surgery in the 798 centers in the year 2008 in the US. And as you can observe, the huge variability in transfusion practice, not only for red blood cells, but also for platelets and for fresh frozen plasma. Of course, the authors were able to identify some factors responsible for this huge variability, factors such as the geographic location, the hospital volume, and the academic status. But even taking together these three hospital characteristics, these only explain 11% of the variation in the hospital blood usage among the different centers. A case mix will explain only 20% of the variation between hospital blood usage. So the major problem is the variability in blood transfusion that could not be simply explained by factors like geographical or hospital factors. What about orthopedic surgery? Similar figures have been demonstrated, for example, by Gombos and co-workers in this recently published Austrian benchmark study. This study evaluated transfusion practice among 18 public Austrian hospitals, including cardiac surgery, orthopedic surgery, and hemicolectomy. But just focus on orthopedic surgery, and here are the figures for the total hip replacement. As you can see, the huge variation here in the preoperative hemoglobin, reflecting the incidence of anemia, the postoperative hemoglobin, which may indicate the transfusion trigger applied in these different centers, and about the blood loss and the blood transfusion among these centers. A huge variation between centers, as emphasized by the authors, not only related to the transfusion rate, but also to amount of blood loss and the use of blood conservation methods. The authors were unable to explain why blood loss was so variable among centers. Again, the same problem. We have a variability, but we have difficulties to demonstrate why is such a big variability. And again, and we know that for many years, the main predictors for allogenic transfusion were the preoperative hemoglobin level, the prevalence of anemia, the postoperative hemoglobin level that may represent the transfusion trigger, and the surgical blood losses. Blood loss are highly variable among centers, but the prevalence of anemia is also highly variable among centers, as emphasized by Arieh Sanders and co-workers recently, indicating that the prevalence of anemia may change from 11% to up to 46%, depending on the study evaluated. So in Belgium, and I'm happy to present you this study. As you know, it's difficult to speak between French and Flemish people in my country, but still we were able to conduct these studies among Flemish and French centers. It's a retrospective chart review of patients, including 23 centers, evaluating the transfusion practice in elective orthopedic surgery in the year 2008. Finally, 2,500 patients were included in the study, and the median number of patients included by centers was 100. As you can see, hemoglobin was determined at least 20 days before the operation in 30% of the patients. However, among 37 of them, hemoglobin was determined less than 7 days preoperatively, indicating that it was not possible to evaluate the incidence of anemia in this particular part of the population. Among the years, we were thought that the population is become aged and aged, which is not reflected by this mean age observed in our population. The distribution of sex was still comparable as those published in other studies. And finally, the number of patients being anemic, defined by a preoperative hemoglobin below 13 grams per deciliter, was 24% in our population. Of note, in this study, patients operated upon surgery in 2008, preoperative iron and erythropoietin was used in less than 0.5% each. This is the distribution of anemia in our population, and as you can see, most of the patients that were anemic, they were moderately anemic, while only small of them have a high degree of anemia. Not surprisingly, preoperative anemia was associated with female sex, elderly age, and revision surgery. Calculated blood loss, if you discuss with surgeons, they will say, why do you try to do something in surgery? My patient is not bleeding anymore. But if you try to calculate the blood loss, taking into account the pre- and the post-operative hemoglobin concentration and the estimated blood loss, in this particular study, patients are still significantly bleeding in this elective surgery, orthopedic surgery. Interestingly, the pre-transfusion hemoglobin was around 8 grams per deciliter, which was a comparable transfusion trigger as observed in many studies, in particular in critically ill patients. Transfusion rate was relatively low, about 17%, but again, 50% of the patients transfused still receive 2 units of blood. Of course, not surprisingly, transfusion occur more frequently among female, elderly, and in patients undergoing revision surgery. And not only anemia, but transfusions were found to be independently associated with a longer hospital stay. As observed by Gombos and co-workers in this Austrian benchmark study, we also observed a big variation among centers according to the mean blood loss, the yellow bars, and the percentage of patients transfused. And as you can see, it's very difficult to find a correlation between the amount of blood loss and the amount of patients transfused. This is the reason why we really need to know and to monitor our individual practice in each of our hospitals, because this variability could not be explained by general markers. We need to measure and then to evaluate our own practice. And NATA is prone to support an European benchmark study that will include 12 centers from 12 different European countries in order to evaluate our practice and to try to improve this practice among these different centers that we will call centers of excellence. Of course, we know that the predicting factors for perioperative transfusion are the preoperative red blood cell mass, the perioperative blood loss, and the transfusion trigger. What we need to know in each center is the transfusion rate related either to an inadapted transfusion trigger, to an excessive perioperative blood loss, or to a high prevalence of preoperative anemia. That means that to evaluate for each center if the best approach is to adapt the transfusion trigger in a multidisciplinary manner, to use pharmaceutical and non-pharmaceutical approach in order to reduce perioperative blood loss, or to use approaches to reduce the preoperative anemia in order to increase the preoperative red blood cell mass. And when we are able to define the predictive factors in the individual centers, then we have to adapt the strategies according to the surgical procedure and technique, the patient's limitations, our own population limitation, the healthcare environment, and the immediate and the long-term costs. I thank you very much for your attention.
So good morning, my name is Schrijvers. I'm a medical oncologist working in Antwerp, in Belgium, and I was asked to tell you something about the use of blood transfusion in oncology. So when we are looking at anemia in cancer, we have different etiologies. First of all, you have some reasons for decreased production of red blood cells. And in oncology, an important part, of course, is the anti-cancer treatment with chemotherapy and radiation. And when you have a tumor, there's also some increased loss due to blood loss. Some diseases are giving rise to hemolysis. So these are the main causes of anemia in cancer. We did, in the beginning of the 2000s, a big epidemiological survey. It was the ECA study, where we studied around 15,000 patients to look at the prevalence of anemia. And as you can see, anemia is relatively prevalent among cancer patients, and around 40% of them are suffering from anemia. This slide shows the treatment of cancer anemia during this survey. A lot of these patients who were anemic didn't receive any treatment, while around 15% of them were being treated with transfusions. So we give a lot of transfusions in cancer. And this slide shows the trigger of the transfusion rate. And as you can see, you have to have a hemoglobin below 9 grams per deciliter before being transfused in half of the patients. When we are starting ESAs, you can see that it starts much easier than that. We are also transfusing more than one unit, and this is a study from the States where they were looking at the number of transfusions. You can see that the majority of adults is getting 2 transfusions per time, while children are only receiving 1 unit per transfusion time. Why are we looking at anemia in cancer? Because it has important implications. First of all, it influences the quality of life. And as you can see, anemic cancer patients are more fatigued than patients with cancer alone compared to the normal population. So it has a big impact on your quality of life. But not only quality of life is influenced, it also influences our outcome of anti-cancer treatment. Here are some tumor types with different treatments, radiation, chemoradiation. And as you can see, patients with anemia have a worse response rate, but also local regional relapse-free survival and overall survival. So it not only implements your quality of life, but also the outcome of the treatment you are giving. We have some guidelines in oncology. They are not very well known, but as you can see, we advise in 2007 to transfuse patients on indication when they have complaints below hemoglobin level 9.0. These are guidelines by the NCCN. And you see when you have an asymptomatic patient, you can wait until the hemoglobin level is below 7. When you have a symptomatic patient, the hemoglobin level where you are in need of transfusion can drop to till 8. And when you have coronary events, the guidelines give you a hemoglobin level of 10 grams per deciliter before you are giving a transfusion. So we are transfusing our patients, but when you are giving a transfusion, you should also be aware that there are some risks. We have procedural errors. They are limited, but they occur. You have the problem of viral and bacterial infections, but nowadays the blood transfusions are relatively safe. You have a direct immune injury, and you also have some immune modulations. And these can have some impact on your cancer treatment outcome. The problem is here we only have retrospective studies, but if you can see in patients with head and neck cancer who are mainly treated by surgery, you see that many of these studies are giving an increased recurrence rate and a decreased survival. So certainly in patients with head and neck cancer, you should be very careful before you are giving a transfusion. And this is also a study in patients that had head and neck cancer, and this were patients treated with induction chemotherapy followed by chemoradiation. And here again you can see that when you transfuse these patients, your overall survival is going down. So transfusion may have an impact in these patients on their long-term survival. In cervical cancer, it's less clear, so most of these studies, also retrospective studies, looked at small numbers of patients and saw no effect on recurrence rate, and also a limited number saw a decreased survival, but overall these retrospective studies didn't show any influence on survival. For colorectal cancer, we have some more data. We have a meta-analysis on the impact of transfusion on surgery in patients with colorectal cancer. And in a large number of patients, they saw an increased recurrence rate. This is a randomized prospective study evaluating surgery, and when you are giving transfusions, these patients are more prone to infections. So you should also use transfusion there carefully. And then this is a last slide on the outcome. And you can see that when you have patients with thoracic malignancies, there is no influence on the survival, but you have an increase in mortality when you are in need of transfusions for these patients. This is a summary slide where you have a combined endpoint, cancer recurrence, dead-due cancer recurrence, and overall mortality. You can see when you are transfusing patients with these kinds of tumors, you see an increased mortality or cancer recurrence or dead-due cancer recurrence. So there is something that influences the outcome when you are in need of transfusions. Of course, we all talk about cost. I also will show a slide. This is an older slide, and you can see that the cost of transfusion is between $200 and $400. This is a recent slide. This is the reimbursement in Belgium, and when you are giving a leukoreduced transfusion unit, it costs 107 euro for the society, and this is not included the fees for the daycare center or the hospital. So it's an expensive thing. In conclusion, we see that cancer patients are anemic, a large proportion of them anyhow. We also have demonstrated a correlation between anemia and the treatment outcome. Problem of transfusions is that the impact on cancer recurrence and survival is not clear. As I already told you, these are all retrospective studies, and we are, of course, in need of prospective studies evaluating the effect of transfusion in cancer patients. Thank you for your attention.
I'd like to talk about a disease that we thought more rare than in fact it is, which is myelodysplastic syndrome. It's a disease that is spread in European countries more or less with the same incidence, but these figures should be in fact a little bit higher due to the fact that myelodysplastic syndromes affect mainly elderly population, and the incidence in elderly population is extremely high. As in Europe, population is increasingly elderly, we will see more and more of myelodysplastic syndromes. And as you see, 80 and older have a very high incidence indeed. Anemia is very frequent in MDS, and MDS, myelodysplastic syndromes, were known as a refractory anemia until a few years ago. Anemia is extremely common, and more than 50% of patients do come and are referred because of anemia and anemia symptoms. And many of patients who present without anemia anyway will develop anemia during the disease. So that very many of the MDS patients will require transfusion during their disease history. And of course, as we know and as we have heard during the morning, anemia leads to increased fatigue. Of course, decreased quality of life brings iron overload because of the frequent transfusion, and the need for chronic red blood cell transfusion brings a lot of problems and issues. In fact, many of MDS patients do require intervention. We cannot just leave them without any intervention, and chronic transfusion or pharmacotherapy are the possible options of therapy, with chronic transfusion still very often used even before trying any ESA or any pharmacotherapy. These are the problems, and some of them have been touched already, like the fact that fluctuating hemoglobin level are indeed one of the problems related to transfusion. Hemoglobin levels are usually maintained below 10 grams deciliter. At least in Italy, we never target higher levels of hemoglobin because of shortage of blood, but also because there are guidelines indicating that the higher threshold, especially for elderly people, are not normal to normalize hemoglobin level. Then there are all the problems like intolerance reaction and infections. Now, there is another very important problem that in my case with the myelodysplastic syndrome is particularly important because it's the quality of life related to the number of transfusions received by these patients. Especially patients receiving chronic red blood transfusion have a quality of life decrease that is correlated directly to the number of transfusion, as well as the increase is related to hemoglobin levels. So the fact by itself to receive transfusion is an important issue for myelodysplastic syndrome patients. As many of you know, we have a prognostic scoring system for myelodysplastic syndromes, which is based on the presence of blast in the bone marrow, on the presence of anomalies of karyotype and the number of cytopenias. This is an old prognostic system that is still anyway very much used to decide the therapy to give to a patient. So we divide MDS syndromes on low and intermediate risk, depending on the score based on these parameters. And low and intermediate one are considered lower risk syndromes, in which the risk to develop acute leukemia is lower and the expectancy of life is longer. Whereas intermediate 2 and high risk MDS patients do develop AML with in a higher proportion of cases, and their expectancy of life is lower than 1 year. But notwithstanding this difference in prognosis, if we look at patients of all risk that do have a transfusion dependency, you see that the fact of receiving transfusion is a negative prognostic factor for survival. So even if you distinguish poor risk patients or intermediate or good risk patients, they all when become transfusion dependent have a significantly shorter survival. And this was very well clear for the patient with refractory anemia or refractory anemia with ring sideroblast. So the patient with myelodysplastic syndrome with a longer survival, with the best outcome. This patient, when transfusion independent, had a much longer survival than the patients who were transfusion dependent. And this may be due to several factors. Maybe the severity of disease is different. Maybe the fact that iron overload or infections or other problems related to transfusion really just influence the outcome of these patients. But indeed, the difference is quite evident and significant. This is so important that the group of Pavia published a new score based again on the morphological appearance, this time WHO category of myelodysplastic syndromes, adding again the karyotype divided in the same category as we just saw. And then they added the transfusion requirement. No transfusion requirement be of course, of good prognosis with a score of 0, and the presence of transfusion requirement regular, so with the IWC parameters scoring 1. And this allows a different scoring, prognostic scoring system, which has recently been validated and which is not yet in current use for myelodysplastic syndromes, but really it indicates the fact that the transfusions may be really important in managing this kind of patients. This is one of the problems. Of course, these patients receiving dozens of transfusions do develop iron overload. One blood unit contains 200 milligrams iron, and overload can occur as soon as after 20 transfusions. So we have to take care of this very important problem, because it has been shown by, again, the group of Pavia, but also confirmed last year by the Spanish group with an incredibly high number of patients, that if we measure ferritin as a surrogate of iron overload, you see that in low risk patient with only erythroid dysfunction, the level of serum ferritin correlates with survival. And this is true as well, but less significantly, for patients who have the dysplasia which affects mostly other cell lines or all the 3 lineages of hematopoietic cells. So ferritin levels affects survival in MDS patients. And an indirect demonstration of the importance of iron overload in this kind of patient is the fact that if you chelate patients appropriately, as has been shown in this French study, you see that the survival of chelated patients is longer than the survival of patients who are not iron chelated. Now, this is an issue and which is object of a big debate. Northern countries don't think that chelation is so important. In the States, chelation for MDS patient is really not considered an important support of therapy. Whereas in Italy, probably because we have a long-lasting experience with thalassaemic patient, we think that iron chelation is very important and may be crucial to lower infection rate, raising neutrophil function, beside avoiding organ damage, which in patients with longer survival, like pure erythroid dysplasia, refractory anemia, and refractory anemia with ring sideroblast, can be important, as these patients have at least 10 years survival. Now, we know since a long time, because this study has been achieved in '98, that MDS patients do respond to treatment with high dose of epoetin alpha, and it has been compared to placebo, and indeed you see that refractory anemia patients respond in half of the cases with a raise of hemoglobin. And you see if the patients are not transfused and they are immediately challenged with ESA, they do respond very well in a high proportion of cases, whereas pre-transfused patients do respond less. And less response is observed when patients are in an advanced phase of the disease, whereas when patients do have blast in their bone marrow and they are approaching acute leukemia. Now, the conventional anemia therapy in low-risk MDS is the one I showed you, and placebo versus EPO was daily, whereas the 3 times a week was also active as a maintenance. But now we think that this dose of 40,000 units a week could be very interesting for treatment of MDS. Higher exposure to EPO, in fact, may be more effective than conventional doses, and the weekly dose for elderly patients is indeed more it's really more feasible. Now, there are a number of Italian studies I cannot present you for the sake of time, but you see that if you have if you treat patients with 40,000 units twice a week, so you load patients with a high dose of EPO, you do obtain indeed very important response. The response is achieved more rapidly and more durably in patients who do not have transfusion dependency and who have not been transfused at all. And you see that if you prolong treatment, you indeed induce more patients to respond with this dose of EPO. Now, who are the patients ideal to be treated with EPO? The Nordic group developed a scoring system in which the patients with higher serum EPO levels, endogenous serum levels, had a low probability of response, together with the transfusion need. So if you have a patient who has a higher than 500 units liter EPO and is transfusion dependent, your probability to get a response with EPO is as low as 7%. Whereas if you have a patient in which EPO levels are very low or lower than 500 units liter, and there is no transfusion need, of course, this patient can have a much higher response to EPO, as high as 74% in the 74% of cases. Now, I learned recently that in renal insufficiency, you do not measure EPO endogenous level. For us, this is a condition sine qua non to start a successful therapy and to avoid unsuccessful treatment. Now, EPO dose is also very important, as I briefly showed you. So we can go from a 30% response to an early 70% response if the dose is appropriately high. So the doses we use are much higher than the dose used in other neoplastic disease, but also much higher than in nephrology, of course. Of course, and we just heard how much is important to keep serum iron at a reasonable level, and in our experience also check B12 and folate levels in this kind of patients. Now, we know that many doubts have been raised for therapy of neoplastic disease and support with ESA. In myelodysplastic syndrome patients, not only is not harmful for developing AML and for progressive disease, but it's important because patients treated with EPO plus GCSF do show an increased and a prolonged survival. So it's not harmful, but it increases survival. So when we had to update the Italian guidelines for management of MDS, we thought that it was with quite a strong grade of evidence that patients with intermediate 1 and low risk MDS and hemoglobin levels lower than 10 grams deciliter with serum EPO below 500 unit liter should be considered for treatment with ESA. So not wait to have lower level of EPO, but treat immediately because the response is much quicker and has a longer duration if you start with higher levels. And we also came to the conclusion and to the recommendation that fixed more than weight-adjusted dose are more effective in MDS, and this is shown very clearly by a number of papers, and that the length of treatment should be quite long, at least 12 weeks, and possibly, and this is related to our budget problems, more than 20 weeks to achieve a response. Some patients, in fact, do respond quite late. Then again, iron supplementation, we mentioned it because it's important that patients treated with ESA have a transferrin level saturation higher than 20%. And then we should try to reduce the dose to the minimal effective dose to maintain hemoglobin level in between 10 and 12 grams. And with this, I finish. Thank you.